Okay, so let me thank the organizing committee for inviting me for this important meeting, and I hope you enjoy it and learn something from it. And as Ronen mentioned, the topic is the importance of reference values, or what we call norms, or both peaks and trendings for CPET interpretation. As recently stated by the AHA and ACC, and I quote, CPET provides a wide array of unique and clinically useful incremental information that heretofore has been poorly understood and underutilized by the practicing clinician. The reason for this include the requirement of additional equipment when compared to ECG, stress ECG that is, a metabolic cart, complex diagnostic algorithms involving up to 30 variables, as well as lack of validation studies, lack of standardization of reference values, and fourth factor, limiting training opportunities, and lack of understanding of the value of CPET by the practicing clinician. Now, talking about reference values, I quote, the essence of interpretation is comparison. However, for valid comparison, we need relevant and appropriate reference values or norms. The selection of normal reference values for use in the evaluation of CPET results is critical to any interpretive scheme. Normal values, maximal and submaximal, provides a comparative basis for answering important questions concerning the normalcy of exercise responses in patients and can significantly impact the clinical decision-making process. Standardization of normal reference values is necessary to facilitate interpretation and optimize clinical application. So let's start with normal maximal values. There are normal values for maximal values and normal values for submaximal values. So we'll start with a normal maximal values. The major portion of the interpretation strategy in CPET is focused on values generated at the end of a symptom-limited or maximal incremental exercise test. These values are considered peak or maximal values, and they represent the existing capacity of the respective function measured during CPET. Now, what you see on the board now is a table put together by the joint ATS and ACCP CPET guidelines in 2003. And in this table, you can see the most widespread references for CPET maximal values. And you see here the studies, the different studies, and you see different characteristics of the studies that were done in regard to peak normal values. And you see here, you don't see it from here, but you see, maybe you see it from here. You see the name of the first author, of course, then the sample size, this is important, then the age of the sample used, the sample characteristics, and you see here the
smoker, treadmill.
Okay, the variables that were measured and published normal values for them, and so on. I would like to draw your attention to a couple of things here. Okay, these two studies, these two studies published by Wasserman Group, Hansen and Wasserman, and the second one is Jones, Normal Jones in McMaster, Canada. And I would like to point the fact that both used very, very small sample size. Wasserman and Hansen used 77 males for their norm establishment, ranging in age from 34 to 74, and Norman Jones used 50 male and 50 females for the creation of their norms, ranging in age, again, from 15 to 71. Now, this is a very, very small sample size to create norms for any variable. They published peak norms for various variable parameters measured during CPET, but not all of them. Now, the other one that I want to draw your attention to is this study here, published by Inbar et al. And we used not 77 or 50 people in the sample, but we used close to 1,500 males and 750 females to create our norms. The age range was 20 to 70, and we published normal values for peak variables. That is, for every single variable parameter measured during CPET. So you could decide which of the three published norms are better and more reliable. Now, the rest of the studies published in this area created norms for very few variables, either one, sometimes two, and the most three, as you can see here, rather than 15 or close to 20 variables that are measured during CPET. Okay. So let's take a quick look at the Inbar et al. Predicted maximal CPET values. Okay, this is a study published in Medicine, Science, Sports, and Exercise, and just to give you the summary of this study regarding normal values for peak parameters, you see here the different variables measured during CPET, and you see here regression equations for each of the variables measured. And by solving for this multiple regression equations, you can come up with a predicted value, with a normal value for any individual at any age, at any height, any weight, level of activities, smoking or non-smoking, and type of residence. And just to give you an example of how you're doing it, which is very easy, let's take an example of the VO2. VO2 is affected, statistically speaking, by age, by height, by weight. As you see here, the constant values for each of the factor here. Smoking does not affect, or did not affect, at least in our study, did not affect VO2 max. And by solving for this multiple regression equation, you come up with a predicted peak value using 1,500 people, not 55 or 70. And the other extreme examples would be heart rate, for instance, that is not affected, its peak value, peak heart rate, is not affected by any of these factors, compared to VO2, for instance, only by age. And the rest of the variables are impacted by different factors that we studied during this study. Just to give you a notion of the impact of using different references for maximum values, I picked a couple of variables, important variables that are measured during CPET: work rate, VO2, ventilation, heart rate, auto-pulse. And you see here actually measured peak values for these variables. A lady 59 years old, 160 centimeter height and 83 kilogram weight, quite overweight. And you can see the percent of predicted of the normal values when using different normal values. And take a look at the huge differences between, let's say, Hansen, Wasserman, and Inbar. 95% of predicted versus 57% of predicted. And you see the differences, this kind of variability among the different normal values in every variable that you measure during CPET. And I must emphasize the fact that those two normal values are the most used normal values in the world for the last 30 years. And you see the differences, and these differences actually affect the final decision when you interpret CPET test results. So this is what I have to say for the peak value, normal or reference peak value. Now let's say something about the normal submaximal value, which are much less popular and known about. And I should say that authoritative textbooks and guidelines advocated that the trending of certain variables is a crucial component of the interpretive strategy, as they might show substantial abnormalities even when the discrete values at specific points along CPET, such as peak values or anaerobic threshold, are still within the expected range. Moreover, the response dynamics are highly reproducible, encompassing a range of exercise intensities which are likely to be faced by the patient in daily life. Although the scientific foundations supporting their use have long been established, they are still not routinely assessed and clinically valued in practice. The main reason for such a neglect is the lack of an established and recognized normal healthy norms for submaximal values or trendings for each variable and for diverse populations. Okay, the following slides intend to demonstrate the specificity of the response patterns among various populations, healthy and diseased. Such distinctiveness should serve as an important agent for an objective and perceptive assessment of CPET studies. Now I show you a couple of typical response curves or response patterns, trendings, of various variables measured during CPET. Let's start with the metabolic-related variables. And here you see some of those figures in the future, I mean in a few minutes. The same kind of configuration, same patients, but different different variables. In this case, metabolically related variable, VO2 and VCO2, and during incremental CPET. And this is the typical Wasserman 9 plot. And here you see the normal response curve for a healthy individual of those two metabolically related variables, VO2 and VCO2. And alongside you see the response curves of those two variables for 8 different clinical conditions. And you see here CAD, coronary artery disease. You see here the typical slopes of PAD. You see a typical slope for cardiomyopathy, pulmonary vascular disease, obesity, COPD, sarcoidosis, and interstitial pulmonary disease. And just glance at these figures, and you can notice the differences in the slopes, in the response patterns for each condition, clinical condition, as compared to the normal one. Peaks, both peaks, you see different peaks and different slopes, shapes of the curve. Okay, just a specific example of these metabolically related variable, VO2, as a function of exercise intensity. You see the normal curve of VO2 over work rate, and you see a typical curve or slope of pulmonary arterial disease, you see the slope is way shallower and the peaks are way different. Okay. Now, typical cardiovascular related response patterns. And you see the same figure, the same patients, same conditions, but this time heart rate and auto pulse. And you'll see, sorry, and please notice again the difference in shape, in the shape of the curves for the different condition, both the curves, the shapes, and the peaks compared to the normal. Okay. Again, typical response curve of heart rate as a function of exercise intensity, and you see here the typical heart rate response to incremental exercise for heart disease patient, respiratory disease patient compared to the normal one. And you see different slopes and different peaks as well. O2 pulse, again, this time you see O2 pulse in different conditions, normal, COPD. The slope is quite similar to that of normal, but the peaks are completely different, much lower here. Pulmonary hypertension, and again you see a flat O2 pulse throughout the test, and here you see the slope, the response curve of coronary artery disease, and the typical downsloping towards the end of the test. Okay. And ventilatory gas exchange, you see the normal one, and then you see the same patient, same diseases, same conditions, and again you can watch the different slopes, the different peaks, different slopes for all the different conditions. Again, a typical specific one, ventilation. And you see ventilation here for lung disease, way steeper than the normal response curve. And you see, in addition to that, a response curve of ventilation. Of trained individuals, the slope is quite similar to the normal, but the peaks are way higher compared to the normal one. And this is a VCO2 slope, which has become very important, I would say, clinical variable. And you can see different slopes for different conditions. Severe CHF, very steep slope. Pulmonary hypertension, steep, but not as steep as a CHF. And compared to the normal one, you have a quantification of these slopes, 25 for the normal one, 34 typical for pulmonary hypertension, and severe CHF would be around even 60. So this is all talking about submaximal or response patterns. And this is end-tidal CO2, end-tidal CO2 and end-tidal O2. Again, just watch the differences in the shape of the curves throughout the test and the differences between the different conditions. And again, this is a response of end-tidal specific one for end-tidal O2 for pulmonary hypertension of progressing severity. Even with progressing severity, you see different slopes of this important variable that you measure during CPET. Okay, so we realize now that different population or pathologies respond differently in most CPET variables. However, in order to objectively establish subnormal response, we need age and gender-related normal, healthy response profiles for each CPET variable. Do we have them? The question is, do we have such normal values for the response curves or the response pattern? Let me show you now. Published in the same study that I showed you before, this one here. We published normal, submaximal, ranges or submaximal patterns of responses for each and every variable during or measured during CPET. Here you see some of the response curves or trending phenomena of metabolic and cardiovascular variables, VO2, VCO2, VO2 per kg, RER, heart rate, O2 pulse, and you notice the differences in the slopes, especially not so much of the slopes, but mainly the amplitude of each slopes as a function of age. You see the same, and this was published in 1994, and this goes further to ventilation, tidal volume, VF, anti-low to anti-CO2, VO2, ventilatory equivalent for O2 and CO2. And again, you see the typical responses based on 1,500 subjects, healthy one, and you see the differences age-related, and you can see that in the last two slides we notice that there are published normative response curves for all CPET variables as a function of relative work intensity. It is also apparent that age exhibits a significant impact on the shape and amplitude of most variables, excluding RER and anti-low 2, with the lowest and highest trendings always being generated by the oldest and youngest age group, respectively. Now, let me show you a few examples of how we could utilize such normative or reference values and responses, submaximal, for an improved interpretive process. Okay, this is, let me move to the other side again. This is a typical Wasserman 9-panel plot displaying typical graphical presentation of CPET results. Now, everybody that is doing CPET recognize these 9-panel plot. This is the most commonly used graphical presentation for the evaluation of CPET results. And glance on this graphical presentation and you realize that there are very, very few, two variables or parameters that have normal values or predicted values for peaks and none for submaximal values. You see, there is one predicted maximal for VO2, and there is another one, the second one, for predicted maximal heart rate. The rest of the variables do not have anything to compare these actual results with. And as I said before in the beginning, the essence of interpretation is comparison. You have to compare those test results with something. In Wasserman 9 plot, you don't have anything to compare it with. Okay. Now, in opposition to this one, take a look at this typical presentation of CPET results with predicted maximal as well as predicted trending ranges. And you see here typical test results, healthy in this case, and you see for each and every variable measured during CPET, you see predicted maximal and you see predicted range of submaximal values. And you can compare each one at any level of exercise, whether or not a value or several values are within, or outside of the normal range or the normal peak value, such as here. Just again, as an example, you can do that for every variable, ventilation, and you see the ventilation here. You can compare the peak values that was here, whether or not it is inside or outside of the normal range for the peaks. Same here. This is the data collected during the test at any level of submaximal intensity, and you can visualize immediately whether or not these values are within or outside, below or above the normal range. Another example for this kind of interpretation is this one here. You see different values, different variables, Benatar equivalent for O2 and CO2. And again, you see whether these values here are close to the peak value predicted, and whether or not they are within or outside. In this case, they are outside of the normal range at some levels of exercise. Same here. See, the peaks are way above the predicted peak, and the submaximal values are also outside of the normal range. So,
Omri, 5 דקות.
Conclusion.
בסדר, okay, so in conclusion,
80%.
as suggested by some of the most prominent CPET advocates, such as Wasserman, Witt, Weizmann, Rocker, and others, a proper interpretation of CPET results should rely on both numerical analysis of variables of interest and assessment of trending phenomena, the response patterns throughout the exercise test. And this is a quotation from Rocker and Witt book put together in 1997. Thank you very much.
עמרי, תמשיך, יש לך עוד הרבה.
שאלות?
Please, time for questions.
You have a question.
Anyway, any questions? Only
Very clear.
very clear. Yeah, you know, the response is very important, especially if patient doesn't reach the optimal capacity or whatever. No, Omri. The response.
They are not less important than the peak values. Peak values are highly important, as everybody knows, but very few people realize and use the maximum normal values to come up with the final decision regarding the test results. And as I mentioned in my presentation, the main reason for that is they don't have normal values, reliable normal values for the submaximal exercise intensity for each variable.
Yeah, but we have it in ZAN, no, in the ZAN system.
I
Yeah,
have
it's
them.
your.
He's too polite to tell you. If you want the norm to be worldwide,
You have to
you have
write
to,
from
you have
ZAN.
to take it to a freeware. You have to open it.
Anyway, thanks Omri for the presentation. We move to the next speakers.